and a very warm welcome to you all. And we have a very special guest today, our Honorable President, National President, Mr. Jayalal sir with us. And as we all know, COVID-19 is persistent for more than a year. We are now accustomed to a new normal, social distancing, mask, sanitization. But still, we have a lot of confusion about drugs being used for treatment, which drug to be used at which stage, and a lot of unanswered questions regarding vaccination also in our mind. Its impact on fertility, pregnancy, fetus, menstruation, lactation, and also how to identify on time which case will progress. Do we need to be careful? Is there any chance of reinfection with good amount of antibodies in our mind, in our body? We need to update ourselves in all these areas. Now, before inviting the chief guest, our Honorable President, National IMA, Dr. Jayalal, to inaugurate the webinar, I take this privilege to introduce our esteemed chief guest to you all. We welcome our National President, IMA, Dr. Jayalal sir. And just a few lines of introduction of sir. Professor Jayalal sir is the National President, Indian Medical Association. He is the National Head, IMA, UNESCO Bioethics Chair. He is MS, FRCS Glasgow, DIS, PHASES, MBA, and PhD also in surgery. He is a very eminent laparoscopic surgeon and professor of surgery, Kanyakumari Medical College Hospital, Asari Pallam. So we all welcome you, sir. So this is a virtual bouquet of flowers for you, sir. Please accept. And I request you, sir, please address the gathering of ophthalmologists, young ophthalmologists, and all the women doctors of Jharkhand.
Thank you. Sir. Yeah, thank you very much, Kashyap. Beloved and distinguished President of IMA Jharkhand, my good friend Dr. Arun Kumar Singh, the Women Doctors Wing National Chairman Dr. Isoda, Secretary Dr. Kavida, the organizing chairman and the very dynamic, enthusiastic entrepreneur and very, very sincere working a doctor of our Jharkhand and the national doctor, Dr. Bharti Kashyap, a person who has been awarded by the Government of India, the the President of India, and very, very dynamic work who is doing on the cervical cancer, and other distinguished members of IMA Jharkhand, the Ophthalmology Association of India, and also the Women Brigadiers of Indian Medical Association. I'm extremely happy and delighted to note on the pretext of JhosWDW and also Ophthalmic Association of Ophthalmic Doctors, Dr. Bharti Kashyap is able to organize this wonderful seminar to dispel the myths on the COVID management and give a correct picture on how to go ahead on the COVID appropriate management and behaviors in this country. Friends, we all in a very, very critical position on behalf because of this COVID pandemic. The people are struggling hard to find the beds in the hospitals, ICUs, oxygen shortage, remdesivir shortage. More than that, now we are going to across the situation of the manpower shortage which is prevailing in this country now. The doctors who are working in this country in the COVID wards are stretched beyond the level. They are working beyond their capacity. Many of them are getting burned out, and we are in a very, very pitiable situation. I am very sorry to report to you, in the last 25 days, we have lost 72 of our doctors, which we have never seen in the first wave. The second wave is very lethal, not only to the country, but also to our medical fraternity. And many doctors of our young age, 50 to 60, has lost their life in the battle of the COVID. And many of our doctors are in the still getting and getting treatment, including many of our leaders in the hospitals to recouping from this corona pandemic. I just want to tell this because I appeal to all my colleagues, all my members of Indian Medical Association and the young brigadiers and the women brigadiers. Please take care of your health and be very sure, be confident on the way in which you are moving around and the way in which you are taking the COVID appropriate behaviors. That is the most important thing. And I'm so happy Dr. Bharti Kashyap is able to organize this meeting where I just gone through the lectures. There are wonderful topics you are going to take. How you are going to make the financial management problem, how you are going to make a single clinic, how to cope with the issues, and the protocol management which she is doing. And I was told by one of the very big entrepreneur doctor, living for a year is the most important than thinking too much on the financial management. But that is not absolutely true. Even when it is a financial management is a very important thing at this great moment, and we need to plan. We needed to tell the ways in which that we need to can go ahead. Probably it is not an advisable time for invest heavily, but definitely it is needed hour for managing because as a for a doctor, it is not only finance for yourself, but for the people who are depending upon you, the staff who are depending upon you. You need to take care of them also. So it is a big challenge. I'm extremely delighted you are organizing this program. I mean, Dr. Bhati Kashyap is very meticulous, very sincerely she is doing this program. I wholeheartedly congratulate her on behalf of the Women Doctors Wing. I'm so happy Women Doctors Wing is rising to the occasion and doing a good job. Keep it up. My hearty congratulations to Dr. Arun Kumar Singh sir, also very veteran leader of Jharkhand and who is spearing ahead the IMA activities. I'm looking forward to hear a lot from you, and I'm sure that you all people will be working hard to see to that our country is safely passing through that vaccination and the COVID appropriate behaviors and safeguarding ourselves is the big challenge in front of us. I wish all the best for this program and looking forward that this will give and empower our practitioners to know the nuances of the medical practice and the clinical practice, and they will be get equipped with to face whatever challenge you are going to face. Thank you very much. Once again, I congratulate you all.
Thank you, sir. Thank you, sir. So now, before we start with the first international speaker, I'm going to introduce the special invitees apart from our respected national president. So now, before we start with the first international speaker, Dr. Ravindra Kashyap. He is based in USA and has done a lot of research in COVID related drugs and lots of research on all these. So I request Dr. Vibhuti Bhushan to introduce our international speaker, Dr. Ravi Kashyap. Dr. Ravi Kashyap, are you there?
Yes, I'm here.
But I can't see you.
Is my screen visible?
Yes, it is.
Yeah, welcome you, sir, Dr. Ravindra Kashyap. It's really heartening to see you taking your time off for this webinar and enlightening us in your specialty. Just a brief introduction. Dr. Ravi Kashyap is the medical director of the UnityPoint-Methodist Sleep Center and associate medical director of the UnityPoint-Methodist Medical Intensive Care Unit. He is also conducting multiple clinical trials associated with COVID-19 infection. He is the principal investigator for the ongoing trials involving treating patients with convalescent plasma, Acalabrutinib, prevention of thromboembolic events using Plavix plus minus Lovenox, and use of agent EBO5, which is a monoclonal antibody. He will be a site lead for National Institute of Health conducted study for post-acute sequelae of SARS-CoV-2, PASC, also known as long hauler syndrome, which is pending approval from NIH. We welcome you, sir, once again. And I hand over the task to you to begin with your presentation.
Thank you.
Over to Dr. Ravi Kashyap.
Thank you so much for that kind introduction. I hope you can see my screen.
Yes, sir, very much.
Yes.
So thank you so much for the kind introduction. And as we are all in this pandemic, I thought we can share some information amongst each other so we can fight this pandemic together. So with that, I think I'll move on with the next slide screen here, if I can. Okay, so briefly, I don't want to spend time on this. I know all of you are aware of it, but just to kind of show this diagram of the COVID-19, in the center, as we can see, there's the RNA surrounded by these proteins, and we keep hearing about this spike glycoprotein. I'm sorry? Can you you're not seeing this? Okay.
I can see. It's visible. Slideshow mein jaiye.
Okay. Is that better?
Yes. Now it's
Okay.
in full screen.
All right. So now, so as we can see here, that the SARS-CoV-2 attaches to cells using spike protein, and this protein binds to ACE2 receptor, a molecule that sits on the surface of human cells. After binding to ACE2, the virus undergoes structural change that allows it to fuse with the cell. Once inside, the virus is able to reproduce. And I'm sure you know all about this. Just want to touch base upon that. I would not go through this slide about the common signs and symptoms of COVID-19. Pretty much it mimics any other viral disease. I want to spend some time on this slide. So we know about the tests, RT-PCR and rapid antigen tests. So I'm going to just differentiate those two. So nucleic acid amplification test is what we know as RT-PCR, and rapid antigen test is antigen test. The intended use of both of them is to detect current infection. Obviously, the nucleic acid amplification test or the RT-PCR detects the RNA, whereas the antigen test detects antigens. The specimen will be from nose, nasopharynx, sputum, or saliva. So what is the major difference between those two comes to this slide, this part of sensitivity. So the RT-PCR test is highly sensitive, whereas the antigen test is moderately sensitive. What does it mean? It means that there are very few false negative with the RT-PCR, where the false negative could be higher in the antigen test. And that's why many of the authorities, including when you're traveling abroad, they would not accept the antigen test because it may miss some infection. They want you to have RT-PCR test. Specificity is high in both. That means there are very few false positives. That means if you are positive with the RT-PCR or with the antigen test, you have a high chance of having this infection. So what's the benefit for antigen test? It is fast, it's cheaper, it can be done on the spot. So many universities in the US, they are doing the antigen test on the students twice a week. So it's cheaper for them to do it and they get the results fast. So there are values to have antigen test as well. Now, I keep hearing about the cycle threshold or CT value for RT-PCR. It is not commonly reported in the US. And the reason is, what is the cycle threshold is basically how many cycles it takes to detect the virus. Higher the cycles, lower the viral load. So if the cutoff is 35, if they don't see the viral load by the 35th cycle, they stop the test. That means the lower the cycle threshold, higher the viral load. So why it is not reported? Because the CT values from viral RNA vary depending on method of specimen collection, specimen source, transport, and the time from infection to collection to analysis. No standard exists to validate quantitative assays that produce a comparable results from labs and manufacturers. Therefore, including the CT value and all positive results may be confusing and sometimes misleading to ordering providers as well as patients. So in general, the consensus is that the lab should not routinely report the CT values, but if a physician asks for it, they should be provided. Why I say that, if somebody's CT value is low and the viral load is high, does not necessarily mean that they would have a more severe infection. Or if the CT value is higher, the viral load is low, does not mean that they would not develop severe infection. It just depends when it was collected, what disease process you were in when it was collected. Now, serology test, also known as antibody test, again, it's not commonly used in the US, but I do see a value of this. So I just want to speak, what does it mean? So negative test on SARS-CoV-2 antibody test means antibodies to the virus were not detected in sample. What does it infer? It means the person has not been infected with COVID-19 previously, or it means patient had COVID-19 in the past, but did not develop or has not yet developed detectable antibodies. It is unknown if all infected individuals will develop an undetectable antibody response. Or it may mean the result may be wrong. It may be false negative. This occurs when test does not detect antibodies, even though the patient may have specific antibodies for SARS-CoV-2. What does a positive result mean? A positive test means that patient is a possibility the patient was recently or previously had COVID-19. There's also a chance it's false positive, as it can detect the other coronaviruses other than SARS-CoV-2, which can cause common cold. And the more important thing is that a positive antibody test does not necessarily mean that the person is immune for SARS-CoV-2 infection, as it is not known whether having antibodies to SARS-CoV-2 will protect them from getting infected again. It also does not indicate whether the person can infect other people with SARS-CoV-2. So I'm not opposed to it, but it has to be interpreted very in details before we make any inference on what it means. Changing gears about the vaccine, I won't spend much time on it, just to kind of consolidate what is available in the world right now. So the Pfizer and Moderna, they have mRNA vaccine. The Pfizer is given 3 weeks apart. Moderna is given 4 weeks apart, two jabs. The Pfizer has pretty stringent requirement for storage, -80 to -60 degrees centigrade. Moderna is -25 to -15 degrees centigrade. Then there's a viral vector, where is a benign virus has the spike protein from the COVID-19, and that's how it makes antibody. And the ones available are the Oxford AstraZeneca or Covishield in India, Sputnik, and Johnson & Johnson. Johnson & Johnson is only one shot. Then the inactivated virus, which is the CoronaVac, the Sinopharm, and the Covaxin available in India. And there's a protein-based, which is a Novavax. Basically, it's nothing to do with the virus. They have taken the protein in the lab and have simulated the spike protein, and that's used as the antibody formation against the coronavirus. I will not spend much time on this slide. You all know it. Basically, the most common way to spread the infection is by respiratory droplets, and it can be it will range up to 6 feet or 2 meters. That's why the recommendation is to stay beyond, to maintain the social distance for 2 meters or 6 feet. Now, it can sometimes be airborne as well, especially indoors. So there is some evidence that if there's in indoors with the poorly ventilated areas, it can linger in the air for longer, and it may cause infection even for the people who are more than 6 feet apart, or even after the person infected has left the room. That's why it's strongly discouraged to be gathering indoors. Again, there are some questions about the contact with the contaminated surface. Not very common, but we need to be careful if there is a respiratory droplet has gone to a surface and we touch it and we touch our eyes, nose, or mouth, then we may get infected. Not a common way of transmission. There are some incidences where the COVID-19 has thought to be spread from people to animals, but the reverse, meaning by animal to people risks, animal to people transmission risk is very little. Again, I won't spend time on this. Basically, wearing the mask, maintaining a social distance, getting a COVID vaccine, washing your hands, staying home and isolate if you're infected, and routinely clean and disinfect frequently touch surfaces, and take other steps to spread at home. Changing gear again, briefly discussing the treatment options, and I would be very clear here that this is all evidence-based. Does not mean that if somebody is treating a patient based upon the clinical judgment is wrong. So what I'm going to present is what is recommended in the US based upon the FDA or CDC. So this is not available in India, but if a patient is positive for COVID-19, they are not sick yet, they are just positive. And if they are at high risk of developing severe infection, so age 65 and above, or a younger patient, but they have a higher chance of developing more severe COVID-19 infection, the combination monoclonal antibody are given. So one of them is bamlanivimab and estisipimab. So this is a combination of antibody, or casirivimab and imdevimab. So there's a monoclonal antibody given as soon as they get the infection, within 10 days or sooner than that. Basically, it fights against the virus and does not let them grow. Has been beneficial. I have seen my patients, and they have said immediately after getting that they got better. Evidence shows that the hospitalization in this population has decreased from 12% to 5%. It is not recommended to be given an inpatient setting. Convalescent plasma was one of the first ones we used. I was part of the study as well. But based upon the evidence as of today, the COVID-19 treatment guidelines recommend against the use of COVID-19 convalescent plasma for the patients hospitalized, unless they are in the clinical trial. And now the high titer convalescent plasma is authorized under EUA, or emergency use authorization, for the treatment of hospitalized patient with COVID-19 and impaired immunity. So we are not using that commonly anymore. Remdesivir is the intravenous nucleotide prodrug of adenosine analog. It binds with the viral RNA-dependent RNA polymerase and inhibits viral replication through premature termination of RNA transcription. It has demonstrated in vitro activity against SARS-CoV-2. So currently it's FDA approved to be used in the hospitalized patients, both for adult and pediatric population, though it is not strongly recommended for people who are very sick, as we'll see in the next slide. So current recommendation is for use in hospitalized patients who are requiring supplemental oxygen. However, it is not routinely recommended for patients who require mechanical ventilation due to the lack of data showing benefit at this advanced stage of the disease. It should be carefully used with the kidney disease, especially with GFR less than 30. Now, so far, the clinical study have not proven mortality benefit. They have shown to decrease the duration of hospitalization by using this medication, and further studies are undergoing. Ivermectin, reports from the in vitro study shows that ivermectin acts by inhibiting the host importing alpha/beta-1 nuclear transport proteins, which are part of the key intracellular transport process that viruses hijack to enhance infection by suppressing the host's antiviral response. In addition, ivermectin docking may interfere with the attachment of the SARS-CoV-2 spike protein to the hemocell membranes. So basically, inhibiting the attachment as well as the replication. But studies have not proven beneficial for the COVID-19 infection and currently not recommended by NIH or FDA, but the studies are ongoing. Fabiflu or favipiravir. It is the antiviral commonly available in India. It is shown to stop the SARS-CoV-2 replication process. Studies have shown to decrease the duration of recovery from infection, and many studies are ongoing across the world. Virafin, which was very recently got the EUA emergency use authorization in India, is an interferon alpha 2B inhibitor. In the past, it has been used for hepatitis C, given as a sub-Q injection 1 dose. Very limited data available in peer-reviewed journals. I tried to look for it. I could not find much information. The phase 2 trial had shown for the mild patients who are not on oxygen, once it was used, the viral load was undetectable in 7 to 14 days more commonly than the people who did not receive that. Phase 3 trials are on the criteria. And the last one is the sickest patient hospitalized and requiring invasive mechanical ventilation or ECMO. Recommendation is dexamethasone plus minus tocilizumab. So that's the recommendation for the society in US. So I'm sure that we are hearing myths and facts, myths from the patients and a lot of questions. I have compiled some of them here. If you look at the language, it is more designed for the population that you'll be talking to. I'll request, if you have some myths, please share that with me. So myth, the COVID-19 vaccines are unsafe because drug companies created them quickly. And the way we respond to that to our patient, that because we are in a global pandemic, drug companies spend lots of time and money quickly making the COVID-19 vaccine, but that does not mean they're unsafe. All vaccines in the US go through strict studies, and so far, and similar in India for that matter, to make sure they are safe and will work. The FDA, in India, there's the Drug Society over there, which regulates vaccine, also approve them before it's being used. Another myth, that vaccines will make me sick with COVID-19. And the way we respond to that, none of the approved COVID-19 vaccine in the US or that other companies are currently developing have the live virus that causes COVID-19. The bottom line, a COVID-19 vaccine cannot make you sick with the disease. Myth, I won't be able to get or stay pregnant if I take COVID-19 vaccine. Fact, the myth has been going around on social media. It claims that antibodies made from the COVID-19 vaccines will bind to proteins in the placenta and stop pregnancy. Scientific studies do not support this idea, and no evidence links COVID-19 to infertility. Myth, vitamin D and mineral supplements can cure COVID-19. Fact, vitamin D and C and the mineral zinc can indeed boost your immune system and protect against viruses. This is mainly true for people who lack these supplements, but there is no evidence that they are a cure or treatment for COVID-19 if you already have the disease. Myth, drinking warm water rinses the COVID-19 virus from my throat. Fact, while water is vital for your overall health, science does not back up the idea that drinking warm water protects you from COVID-19. The only thing it might do is to soothe your throat and ease the cough if you're already sick. Myth, taking a hot bath can stop COVID-19. Fact, the idea behind this myth is that high temps can kill the coronavirus, but taking a bath in water that's too hot can burn your skin. The best way to ward off COVID-19 is to wash your hands with soap and warm water. Washing gets rid of viruses on your hands so you could transfer to your eyes, nose, and mouth. Myth, rinsing my nose with saline will stop COVID-19. Fact, there is no proof that rinsing your nose with saline protects you from getting COVID-19. This myth may stem from the evidence to use saline in your nose or to treat a common cold, but it does not actually stop infections. Myth, I have a COVID-19 infection, so I'm immune. Fact, scientists have studied similar viruses and say it's possible to get COVID-19 more than once. They are still learning more about how likely you are to get infected again, how often it happens, and who has a higher chance of getting the disease again. Even if you have had COVID-19, you still should wear a mask in public, stay away from the crowds, and wash your hands. Myth, I have allergies, so I cannot get the COVID-19 vaccine. Fact, in rare cases, some people have developed anaphylaxis to the COVID-19 vaccine. If you are allergic to any ingredients in the COVID-19 vaccine, you don't get the shots. But if we have an animal, food, pollen, or other types of allergies, you can get vaccinated. Myth, a negative COVID-19 test means I'm not infected. Fact, if you test negative, it only means you likely didn't have COVID-19 when your sample was collected. It is still possible to test positive later and get sick. Researchers have also found that some tests show a false negative result. So even if you test negative, you should still protect yourself from the virus. Myth, small gatherings don't spread COVID-19. Fact, nursing homes, prisons, and other large groups in close contact are driving the spread. But small get-togethers are still a source. You raise your odds of getting COVID-19 when you gather with people who are, number one, outside of your household, means okay to stay with your household people, not social distancing or wearing masks. And keep in mind that some people with the virus don't show symptoms but can still spread it to others. Myth, children who develop COVID-19 don't get critically ill. Fact, most children with COVID-19 have mild symptoms or no symptoms at all. However, some children get severely ill from COVID-19. They may require hospitalization, intensive care, or mechanical ventilation. In rare cases, they may also die. Although the CDC reports fewer children have been sick with COVID-19 compared with adults, children can be infected and become ill with the virus that caused COVID-19 and also spread the virus to others. Children, like adults who have COVID-19 but have no symptoms, can spread the virus to others. Myth, there are no long-term effects of COVID-19. And this is a hot topic right now. We call them long haulers. In fact, there's a study being conducted by NIH, and I'll be the site lead for that study. It'll be a long study. So the way we explain to the patient is that while most patients with COVID-19 infection recover within a few weeks, some people, which is up to 10%, who had mild version of the disease, continue to experience symptoms after initial recovery. These people are often referred to as long haulers. Older people and those with many serious medical conditions are the most likely to experience lingering COVID-19 infection, but even young, otherwise healthy people can feel unwell for weeks to months after infection. The most common signs and symptoms that can linger include fatigue, shortness of breath, cough, joint and chest pain. And I'm seeing more patients are also complaining of fogging of the brain, that they forget from time to time. In addition, organ damage can occur to the brain, heart, and lungs. Much is still unknown about how COVID-19 will affect the people over time. Myth, COVID-19 is an invented pandemic to cover up the effects of 5G radiation. Fact, 5G is the 5th generation mobile network being rolled out across the US and the world. The belief that COVID-19 and 5G are connected comes from a long-standing myth that wireless signals can sicken people, specifically with electromagnetic sensitivity, or they may weaken your immune system. There is no evidence to support these claims. To be clear, COVID-19 is a real disease that has affected lives of millions worldwide. There is no connection between rollout of 5G technology and the COVID-19 pandemic. Myth, wearing a mask will increase the amount of carbon dioxide I breathe and will make me sick. Fact, for many years, the healthcare providers have worn masks an extended period of time and with no adverse health reaction. The CDC recommends wearing cloth masks while in public, and this option is very breathable. There is no risk of hypoxia or hypoxia, which is lower oxygen levels in healthy adults. Carbon dioxide will freely diffuse through your mask as you breathe. If you feel uncomfortable in your mask, try to limit talking and breathe through your nose. This will reduce the humidity level in your mask. Myth, COVID-19 vaccine affects menstruation and makes them irregular and heavy menstruation. Fact, no scientific evidence suggests that COVID-19 vaccines are making periods irregular. Many female patients with COVID-19 infection have reported heavy menstruation. Some females have also mentioned that they have experienced irregular period after COVID-19 vaccine. Myth, COVID-19 vaccine should not be taken by breastfeeding mothers. Fact, Because non-replicating vaccines pose no risk for lactating mother or the infants, COVID-19 vaccines are also thought not to be a risk for breastfeeding infant. Therefore, lactating mothers may choose to be vaccinated. And then take-home message, as you know, use masks, wash your hands, maintain social distancing, avoid indoor gathering, and please take the vaccine. So with that, I will take any questions which if you have.
Unmute yourself, Dr. Bharti.
Yes, I have two questions. Number one, uh, how to reconfirm hypoxia means we know that we have to take it here, but sometimes in the right middle finger we take, sometimes the reading comes low, sometimes after some time it comes high, and sometimes it is showing 93. So how to reconfirm it means, is the 6 minutes walk test is essential? First question. The second question is, how to prevent the silent hypoxia, because many patients, they complain, many people around us who have come back after recovering, they complain that suddenly their condition starts worsening, and after coming back from hospital and the oxygen level starts going down. So how to recognize and how to prevent this silent hypoxia?
So good question. So let me just answer both questions in one. I mean, explain both things. So what we recommend, anybody who is positive for COVID-19 or they are highly suspected to have COVID-19 infection, to use the pulse ox. So one of the most important things is to have a good pulse oximeter, good reliable pulse oximeter. Now, whichever finger they are checking the pulse ox should not have any nail polish, because the way the pulse ox works is by looking at the color of the nail bed. So there should not be any nail polish at all. So that should be clearly visible. Now, when you check the, so that's one thing. So checking the pulse ox is very important, and we'll discuss in a second. Now, checking the pulse ox, if you just put the pulse ox on your finger, it may fluctuate. So wait for a second. Do not be panicking if you say 85%. Keep it on. And the pulse ox also shows the heart rate, pulse rate. So the way we say that, make sure the heart rate matches with your pulse. So make sure, then you know it's actual reading. Because if your pulse rate is 60 and your heart rate is 80, that means it's not real. And also look at the waveform. But the most important thing is, for the patient, maybe a little more difficult. So I said, well, if you say 85%, don't panic. Just take some nice slow breathe and keep for a little bit and make sure it has stopped fluctuating, that it is stabilized. Keep your finger steady, put on a table or something, keep it steady, and let it stabilize. And when it becomes steady, you know the numbers, right? So that's number one. Number two, if your oxygen level is, say, suppose about COVID-19 infection, you have flu-like symptoms and they have confirmed, and they saturate 98%. What I recommend, and I'm not saying that everybody should recommend that, but I recommend stay home. If you have fever, take the analgesics or Motrin, ibuprofen or paracetamol if you need to. But stay home, maintain a social distancing, and make sure that stay away from other people in the family, or wear a mask, wash your hands, etc. Vitamin C, zinc, vitamin D, there's no harm taking those. I don't think there's a problem. They should take that. 6-minute walk evaluation, if there's any concern that, if it's basically what it is, that we need more oxygen when we walk. So if you're really concerned and say, well, I don't know, my SAT's 98%, but would it drop? Well, good point. So, you 6-minute walk, whatever time you can walk at the normal speed that you normally walk, go back and forth without stopping, keep the pulse ox on your finger. Now, don't believe the pulse ox when you're walking, because sometimes as you are, it may be fluctuating. Once you get tired a little bit, then, or you walked for 6 minutes, then sit down, steady your finger, and check your pulse ox and see what the numbers are. So yeah, it's a good idea. When to panic, or not panic, when to be alarmed if your oxygen level drops by 3 to 4%. So for example, today is 98%, and tomorrow is 98%, and third day is 94%, and it's steady, that's the time to be concerned. That's when you need to see, everybody should see the doctor to see what to do. Do a CT scan? And beyond that, I would not go to the treatment process because it's very individual. But that's the time I would recommend to have some treatment that could be more invasive, being hospitalized, maybe, remdesivir or steroid, whatever that may be, is very individual. But that's when the people should be concerned getting more invasive testing done. 95% people would probably need none of that. At least 90%, I don't know with the new variants. So a vast majority of patients will do fine by just staying home, taking paracetamol, etc. Yes.
Bharti,
Yes.
I have got a question. Few questions.
Sir, Anand Thakur sir has a question. Please, sir.
Absolutely.
Yeah, my first question is, I don't know whether Papu remembers of me or not.
Of course I do.
Thank you. The first question is there any role of antihistamines together with paracetamol when there is early stage of fever and cough?
There's no proven medicine for antihistamine, but it's very benign medication. If you really want to take it, you can take it. I don't know antihistamine will have a high role. On the other hand, some people are suggesting, which is a little more safer. And again, it is not evidence-based, and I'm just talking just what I do or I recommend. So this is not, I'm not going to back up with any evidence. I would recommend inhaled corticosteroid. If you really want to be like, okay, I want to do something, I don't want to be more aggressive, inhaled corticosteroid would be probably safer to do at that point. I don't have any evidence to back that up. But if that's a concern, that I would recommend that personally.
Actually, what I feel, I'm not talking about the condition when the RT-PCR is positive. No RT-PCR test has been done. The person has simple mild fever, cough, a little cold. So in that situation, just I asked you whether we can go with the antihistamines together with paracetamol.
Yeah.
Then,
yeah.
two,
I mean, it hurts with allergies. So yes, definitely, no question about it. Just for symptom relief, I don't see any problem with that.
Right. Number two, in the first phase last year of COVID-19 in India, the recommendation of drugs were different. People used to give a lot of SCQS and azithromycin. Now, this in second wave, I see that for prescriptions that they advise for the say suspected patient or for the convalescent patient, that is doxycycline. Is there any role of doxycycline in improving COVID-19 cases?
There is no, again, this is by no one of the proven antibiotics, any antibiotics have been proven to be helpful. So whatever works to prevent the secondary infection, as long as they're safe, there's nothing wrong doing that. But there's no evidence to show antibiotics work.
Okay. The most important question that I want to know from you, what should be the oxygen level when a person should feel that I need really some very good hospitalization? Because I have seen in my cases, for routine cases that I do cataract surgery, I always get examined pulse oximeter each and every patient. And I remember a few patients who have got oxygen level of only 85. Repeated checkups, lot of breathing, lot of deep breathing I got done, but it didn't improve. Then I sent to the physician. He also checked thoroughly, spirometry, this and that, all tests. And then his report was, his 85% is okay for him. Go ahead with the surgery, there will be no problem. And there was no problem. And in my personal family, nowadays we are doing regularly pulse oximeter testing of entire family members. What I didn't know was that nail polish. That nail polish that you have told me today, now I will take care of it. Number two, sometimes the oxygen level comes to say 88, 89, 85 to me also, to my family members. And when we breathe a little, 3-4 times, 5-6 times, deep breathing, it just goes high as 95-97%. So normally, in normal circumstances, if all this is there, even after a few breathing exercise, if the oxygen level remains at around a 90, 92, is there any need of oxygen supplementation immediately?
So good question. So number one is that the patient you described that has 85%, I may have to disagree that they would not need oxygen, COVID or no COVID. So anything below 88% consistently, especially at rest, is 85%. On walking, they may drop 80%, and they will cause pulmonary hypertension and like heart failure. So clearly, the patient who need oxygen, based upon the patient you described, not COVID, just in general, they will live longer if they use oxygen. So this is well proven. So I would do more testing to see a COPD is the most likely cause. Interstitial lung disease, they may have a shunting in the heart. I mean, there are multiple things. Not going through that, but yeah, they need to be on oxygen till it's recovered. Now, for COVID-19, knowing the baseline is important. So in general, if this less than 94%, it's not necessarily giving them oxygen. Is to be more concerned that do they need more invasive treatment now, would be dexamethasone or remdesivir or whatever that may be. So giving oxygen is one thing, but more important is to be careful about these patients that they are deteriorating, meaning they're getting a CT scan, etc. So more than giving oxygen is to be giving them more treatment. Now there will be some patients like you had described. Some people may have 90. So 94% is the number normally they are recommending to be very careful about. There could be a patient with COPD. The baseline oxygen may be 94% to begin with, right? Then that's very difficult one to determine. Then you say that typically what we do is they drop by more than 3% from the baseline. So if they're 94% all the time before COVID, then we want to make sure that they're dropping by 2 or 3%, or get the CT scan of these patients sooner to make sure that we're not missing anything. Plus, they're at high risk anyways because they have COPD.
Thank you. Thank you very much.
You're welcome.
There is one question, simple questions, that the patient who are COVID positive frequently ask you when, at what frequency you should check the oxygen level?
I would say 2 or 3 times a day.
But they said there is a study which says every 4 hours you should see the oxygen level saturations. I don't know what is the authenticity of the study.
I don't think any recommendation, but I mean, it does deteriorate. I think one thing about the COVID we have seen, especially in ICU and all, they don't deteriorate like on hourly basis. So they're very slow deterioration and they keep going down the hill. So if every 4 hours works, that's fine. I don't know, I will wake them up in the middle of the night, but at least checking 2 or 3 times a day to, in the morning, in the afternoon, in the evening, make it 4 times. I think there's no regular recommendation, but it won't hurt.
And sir,
good evening, sir. Good evening. I have a question. Can I have a question, please? Good evening, sir. I'm
Yes.
Dr. Anupam Singh. I have a question, which is a
Yes.
case myself. This is my case. I was diagnosed as COVID-19 positive on the 13th of this month by the nucleic acid amplification test, because here RT-PCR is, by the time you get the report, another strain comes up. So I was tested positive, and after 14 days of the treatment, I was even on favipiravir and other drugs like doxy, ivermectin, and other things. And after 14 days, when I got tested, I was tested negative by the same test, what we call it TrueNat. So and again, after like say 4 days, I again got retested because initially I was asymptomatic, absolutely. My husband was tested positive first, and I contracted from him. So I got tested, and I got tested positive. But I never had any symptoms during those 14 days. After which, when I got tested yesterday, again, I was tested to be positive. And for the last 2-3 days, I'm having eye symptoms. I'm having itchiness of eyes, pokiness in the eyes, a mild chest discomfort, diarrhea, sore throat. So I actually want to know, what we have known so far is that the virus replicates during the first 9 days of the infection. So I have a serious question, that what about the infectivity? Am I still infectious? Do I still need medication? Or how should I go about it?
So, because there's a possibility you got reinfected. So what I would recommend is from the second exposure, you should again quarantine for 10 days. So
what about
meaning by
the
you
medication, sir?
Unless until you have symptoms. I mean, obviously, if you have chest discomfort and hypoxia, I will get the CT scan done. But I don't know that.
I haven't had a CT scan done, and I'm not having hypoxia either. My saturation is doing fine. It's in 98, 99 all the time.
Okay, and that's what I was saying, that this is very individual, physician driven treatment. If suppose, and I give my opinion, if you're my patient, and the way I mean, I would not have treated you from the beginning itself. That's my opinion. This is my treatment plan. I would have said, take the paracetamol or whatever you need to take, check the pulse ox. Now, obviously, with the diarrhea, you need to treat that, loperamide or whatever medication you want to take for that. But I would not have treated you with any other treatment beyond the supportive treatment. So I would still recommend for you, if you go with evidence-based, that just do the supportive treatment, but take the precaution for next 10 days from the second time you got exposed.
Okay, sir, but I never got the exposure. And what about the medication? Should I go ahead with anything, or and what about HRCT? Should I get it done, or I don't need it?
If your pulse ox remains 99%, I don't see a value of the CAT scan. If you're really concerned, you can take the pulse ox after walking and see if that shows anything.
Okay. Thank you so much, sir.
But otherwise, supportive care is what is recommended, and it's the safest way to go.
And no other medications, no antivirals, no indications of that?
And as I said, we don't, and we have. There's no. I mean, antivirals have shown to decrease the viral load. But that's too late for that now.
Yes, sir.
But I don't know that it'll be safe to give any medication at this point.
But I'm still infectious. Is that what you're trying to say?
If it's positive, you got exposed to your husband, you said? That's what I heard?
Yes, but he was infected before me, and now his infectivity level is low. He is still positive with a low infectivity. So I am seriously confused whether like we are still infectious, or how should we go about it?
No, so no, that's a good question. And you or anybody could be positive up to 3 months. We have seen patient ICU after 45 days. So typically the recommendation now is that you have to quarantine for 10 days from the day you were positive, or the day you were exposed, or the day you develop the symptoms, and 24 hours symptom free.
Okay, sir. No, I was also confused about whether the reinfection is happening, or is this a post-COVID sequelae?
It's most likely post-COVID sequelae, and we don't know. There is we're still trying to learn whether the reinfection happens or not. Less likely, but possible.
Okay. Thank you so much, sir.
You're welcome.
Sir, I have a question.
Sure.
Sir, yeah, I want to know that if a patient comes to us with the COVID negative report after he has been COVID positive, after how long is it safe for us to operate for a cataract surgery? So after how many days should we operate the patient?
10 days after they have been positive, you should be safe to do the surgery. If you're in close contact though, if you're in close contact like your surgery you're doing, it may not be a bad idea. Yeah, it may not be a bad idea to get that COVID negative testing done and turn them to quarantine. So typically what we tell them, that get the testing done and stay home. Don't get exposed. Okay. And the testing comes back positive, you can do the surgery. Meaning what I'm trying to say is that even if they were negative and they have been exposed after that and you do surgery, you may be exposed.
Excuse me, sir. One question.
Sure. Yes.
Yeah, what is the role of low molecular weight heparin?
Good question. So what we are seeing in the patients with the more severe infection, especially in ICU, there's high incidence of the DVT and PE. We are seeing that. Now, I don't know how to, we don't know how to prevent that. So even they are on the low molecular weight heparin, they may develop the DVT and PE.
What is the dose, sir? What is the dose that we can use?
So outpatient, we don't recommend anything. Now, I'll tell you what we do, and it's not fully scientific based. So what we do is the half dose. So for example, as you know, like, we do the Lovenox and low molecular heparin, 1
do
milligrams sub-Q BID.
sub-Q.
We do 0.5, half milligram per kilogram body weight BID. But that's our practice. That's what we're doing.
So actually, we have started our COVID facility just now, and we are treating patients with oxygen saturation below 90.
Yes.
So that's for them. We are thinking to start them on low dose heparin. So
yes,
what
I think
can be started for them?
So the Lovenox would be 0.5 milligram instead of 1 milligram. 0.5 milligrams per kilogram ideal body weight sub-Q BID will be middle of the road. And if you see that, and now I suggest check the D-dimer of these people, because D-dimer will be more beneficial for these sicker patients. If you start seeing the D-dimer going like based upon your level, like our levels is 0.5 being normal. So if you go to 2 to 3, then we get concerned. If there's no contraindication, with fully anticoagulate them. On the other hand, if the D-dimer is less, like 0.5 or 1, high but not too high, we go for the half the dose. And again, this is very much our individual approach, no scientific based, not scientifically based.
Okay, thank you, sir.
You're welcome.
Sir, I had one question.
Sure.
Yeah, sir, this is regarding one of my senior doctor's husband. Like recently, our hospital has also been made COVID center. So, sir, this is his 11th day of infection, and he's on BiPAP. Like his oxygen saturation has been falling like below 60 for past 2 days. So he's on BiPAP and he is maintaining like around 74, 75. So here
it's a PO2 or saturation?
SPO2, sir, SPO2.
SPO2, okay.
Okay, yes, sir. And we have started, like earlier he was on intravenous dexamethasone and then enoxaparin and other IV antibiotics. But then someone suggested to start him on pulse methylprednisolone IV. So from last night, because his saturation was falling, yesterday it was below 60, SPO2 was below 60. So we have started in on IV methylprednisolone 500 for 3 days. So sir, any other like quick, because here his D-dimer has not been done, but then the neutrophil lymphocyte ratio that is quite raised. But he's on BiPAP. Yes,
not on oxygen?
With the that low saturation, I would say recommend to be patient to be on the ventilator. I mean, the saturation is only 75%.
Yes, sir. He's on a non-invasive that BiPAP, but not on invasive one, but on non-invasive ventilator.
But then, is he on oxygen?
Because that.
Yeah, yes, ma'am. Yes, ma'am. Along with that, oxygen is also high flow oxygen.
That's not enough. Like 75% is, is not.
Yes, sir. Yes, sir.
Very good. But beyond that, no, that's one thing I would recommend to be intubated. But beyond that, I would say, if the D-dimers are D-dimer, is available.
Okay. Hello.
Yes.
Hello.
And I would.
Hello, sir. I have one question. Please emphasize again, sir, on vaccination on breastfeeding mother,
Thank you, sir.
women, and post-COVID patient.
So, breastfeeding with the vaccination has shown that it does not interfere with the breastfeeding. It does not cause any problem to the child. So it is recommended to give vaccine to the breastfeeding mother.
Okay. And in post-COVID patient?
Post-COVID patients, as long as they're recovered, and I would say when there's a recover, meaning by at least 10 to 14 days after they were positive, they should, once they develop antibody, they should be able to breastfeed.
Excuse me, sir. So what is the level of antibody titer so that we can think we are immune at least for 3 months?
Yeah, as I was saying, we don't know. I don't think antibody titer has much value at this time. We don't know we definitely will develop the antibody. We don't know what level will be protective. So that's why it is not till it is validated. There's no validation done yet. So antibody test really at this time, other than the fact showing that you may have been exposed, has no other value. But there's no validation with any research that this is this is a good level, this is not such a good level. So I would not recommend to base any clinical judgment based upon the antibody test.
This is a real confusion here. Many people think that their antibody titer is 190, 200. So they are very safe, and people who develop antibody very less, like 20, 15, they are more prone. But now with your talk, it is very clear that antibody titer thing and protection from COVID-19 at the moment has no validation. And I have one question: how you will differentiate an inflammatory pneumonia from a clot? A lot of talk going on, inflammatory pneumonia, then this is clot pneumonia.
Yeah, and I mean, I think that what they might mean is that the pneumonia with the DVT and PE. So that's what they might be meaning by that. So obviously, inflammatory pneumonia is what the COVID-19 pneumonia would be. That's the reaction to the COVID-19. Now, if they also have the DVT and PE, and that will be more like developing clot, and that's a very difficult thing, because I tell you from my practice, I have been unfortunately lost a lot of patients, but you also see that if you give them too much of the anticoagulation, they may bleed. So they are also high risk of bleeding. They're also high risk of DVT. So we keep a very close eye onto it. And it's very difficult balance to maintain. That's why we went with half the dose of the anticoagulation if they're not positive. And the moment we suspect they have DVT PE, then we immediately send them for testing, confirm it, and do the full dose.
Sir, one question I have got. We are asking patient for RT-PCR before all the surgery. So validity of the test, because we are getting the report after 2-3 days. And within how much time we should operate that patient?
So that's what I was saying. Typically what we recommend that you get the RT-PCR test done and isolate. So if it takes 2 or 3 days, we should wait for 2 to 3 days. But for those 2 to 3 days, the patient should isolate themselves, so that if the PCR test come back to be negative and they have not been exposed to somebody. So whatever time it takes, don't hurry. I think I will wait for them to get tested. It's saving you and your staff from getting infected, because you'll be in close contact with those people, those patients.
So another question, when do you become eligible to donate plasma after having an infection?
So, the typical recommendation is anywhere from about a month, 15 days to a month after being COVID negative. You should be eligible to give the plasma.
And how frequently can you donate plasma?
As long as it's safe, based upon the local the guidelines, as long as it's safe to give plasma, meaning to draw the blood. And I think it could be every 3 weeks to a month, just to save you from not getting too much blood taken out. But it should be every month or every 3 weeks.
Okay, thank you, sir.
Apart from drug sessions, I just wanted to know your take on lockdown in this community transmission period. Is it effective?
It is effective. There's no question about it. We have seen that in our community itself, and we have seen the surge following a major event. And I'll tell you, like, for example, we have a Thanksgiving and people get to meet, and it's very important for the people. And we have seen a surge post Thanksgiving, 14 days after that. We've seen a surge 14 days after the Christmas. And right now we're going through a surge, a pretty severe one, with the spring break. Spring break, people go and meet, and so we see the surges. So it's clear that if the people stay locked down, meaning by, I won't say lockdown. What I'm trying to say is to separate and maintain the distance 6 feet.
So 2 weeks will be effective, or it will be like 3 weeks or something like that?
How long to isolate?
We isolate for 2 weeks, I think.
Yeah, I mean, and again, follow the local guidelines. I would highly recommend that. What we have recommendation local guidelines, our guidelines is 10 days from the day of exposure and 24 to 48 hours without any symptoms. But 14 days is even better. I think I would argue against that.
Yeah. So I have a question, like if the antibody titer plays a role in for plasma donor selection. I mean, if somebody has 15, 20, somebody has 190, So what is the cutoff mark for plasma?
There's no cutoff mark, but the higher the, so as I was in the beginning, the higher antibody titer that is supposed to be more effective. But even that did not pan out. So right now, the plasma is not recommended for any hospitalized patient except if they're immunocompromised. I would not say not use it, but the evidence does not show any benefit. But to answer your question, the higher the titer, the more effective it's supposed to be when you're given as to the patients.
So what titer is supposed to be good? Means 80, 100. What titer you say good?
Yeah, I mean, depending on the local level. So I think the higher, I mean, above 1680 would be high titer. So there'll be high titer value. Low titer will be like 15, 20, and then in between will be medium titer.
Plasma is only for hospitalized patients who are immunocompromised?
Yes. And as I said, we use that quite a bit in the beginning, every patient. And again, I was one of the site lead for the research done by Mayo Clinic. And the study came out and it showed that even with the high titer plasma, there was no benefit. As I said, and again, I will keep repeating myself, it's okay to treat the way you want to treat your patient. It is your prerogative and you should use that. All I'm saying, what evidence is showing that the plasma has not been found to be beneficial.
So I want to
Sir, I've also read somewhere that people who are symptomatic, their plasma seem to be more immunoprotective than the people who are basically asymptomatic. Is it true?
I have not seen anything like that. On the other hand, I'll be very concerned giving a blood from an infected person to anybody else, because if they in the viral phase, that means that they may be transmitting the infection. So I know I have not heard of symptomatic patients getting the giving the plasma. Plus, the antibodies should not, in general, just speaking from the common knowledge, that should not develop so quickly. And it is the antibody which is supposed to be protective, not the not anything else. I have not heard of that, and I don't know I would support that.
Okay,
thank you, sir. We know that plasma is given only from those people who are negative, and there are certain after 3 weeks they become negative, because by that time they have by that time they have
antibody.
Yes, we are starting.
One more question.
Sir, I wanted to know. For immunocompromised patients, those who are suffering from cancer, those who are elderly, whether co-vaccine is better or Covishield. Is there any difference between taking Covishield vaccine or co-vaccine?
So, I have a request. We have to sum up here, because the other two speakers are getting late. So we can continue with Ravindra Kashyap after those two speakers, if you are interested. So, so we can reconnect with Ravi Kashyap after those two talks. So let's first sum up this session. And I invite Dr. Beauty Banerjee, the Vice President of Women Doctors Wing, and my batchmate also, to conclude the session 1. And then again, we will come with the conversation part with Dr. Ravi Kashyap. So, okay, over to Dr. Beauty Banerjee.
Good evening, doctors. This was an excellent topic and discussion. The discussion was brilliant and very interactive indeed. Thank you so much, Dr. Ravi, for taking out the time for all of us and laying out so many things about COVID and all the myths. We were treating unnecessarily, actually. We were giving so many drugs which are actually not necessary. And you emphasized all of them. This webinar was a need of the hour and would not have been possible without her hard work. Thank you so much, Dr. Bharti Kashyap, for getting very interactive session. And thank you, Dr.
Thank you, Dr. Beauty. And this webinar has not finished.